Systemic mycoses are the ones that are definitely far more dangerous. And when we're talking about systemic mycoses, what we're talking about are dimorphic fungi, meaning they exist in a mold phase, mostly in the environment, and then the yeast phase when they're inside the host. And these are capable of causing infection in healthy individuals. What we typically see with any of our systemic mycoses are that they begin as an infection in the lungs. So it's an inhaled infection. And from the lungs, these fungi are often able to disseminate to the rest of the body. So again, these are endemic pathogens, meaning they are fungal organisms that typically exist in the environment, and their spores are released from the mold form or the saprobic environmental form and can be inhaled and then reproduce asexually inside of the host. This is an image showing most of the endemic or systemic mycoses that are found worldwide. Some of them we've talked about a little bit. Some of them we're not going to talk about at all. And we are really, of course, going to focus on those that have incidence or cause disease in the US. The first genus we're going to talk about is Blastomyces. And what we can see from the map is that this is going to be in the Midwest to the East Coast of the US. So Blastomyces dermatitidis forms yeast cells at 37, and it reproduces by budding. Okay, so that's what they're trying to show in the image here. This genus, Blastomyces, is typically found in decaying organic matter. And typically we see infection in people who have outdoor occupations or who tend to spend a lot of time outdoors doing recreation. It is possible that there is some level of genetic susceptibility that can make people even more susceptible to infection. For example, in Wisconsin, there was a really large outbreak in people, in Hmong people. So people who either came over from that region or who are of Hmong descent, even though people of other ethnicities did not experience that same level of outbreak. So there may be some type of genetic susceptibility. With Blastomyces, we don't typically see person-to-person spread. It's going to be from the environment. It's going to be inhaled. You see a dog here, so it can infect pets as well. There have been laboratory-acquired infections, and that's why it's really important to be very, very careful when working with any of these systemic or endemic fungi, because as they grow and they produce spores, it's entirely possible that you would inhale them. So often if you are working with these organisms, you may want to wear some sort of respiratory protection. Every year, per 100,000 people, there are 1 to 2 human infections. The numbers are higher in Wisconsin, so this is a more common fungal infection in Wisconsin, 10 to 40 cases per year per 100,000 people. And in dogs, the infection rate is much higher. Dogs are closer to the ground. Dogs, if you have dogs or you've been around dogs, you know they're constantly sniffing. So it's really not surprising that dogs would have more exposure to the pathogen. As with any of our infections, like literally everything we've talked about all semester, the severity depends on the exposure level. So did you inhale a lot of spores? Did you only inhale a few spores? And the immune status of the patient. If you're otherwise healthy and you only inhaled a couple of spores, you may not even develop symptoms, or they might be really, really mild. But if you have somebody who's maybe a little bit immune compromised or inhaled a bunch of spores, the infection might be more severe. Symptomatic disease occurs in about 50% or so, maybe a little bit less than that, of infected individuals. We do tend to see extrapulmonary disease. What you're seeing here are some skin lesions, but the fungus can also affect the bones, the prostate, liver, spleen, kidneys, central nervous system, when it gets outside of the lungs. In patients who develop pulmonary disease, you're going to see basically flu-like illness. Everything causes flu-like illness, right? Oh, you're tired, you're having difficulty breathing, you might have a fever. But with this, it can progress to pneumonia and respiratory failure. The chronic form of infection can resemble TB or lung cancer. So you might see pockets in the lungs, and until you get in there and look at those pockets, it's hard to tell, are they a tumor? Is it a granuloma from tuberculosis? Is it a fungal infection? So X-ray is just a tool to use to identify that there might be a problem in the lungs. The infection can be diagnosed by microscopy of the tissue, of sputum, or you can even do a lavage. And if you don't know what that is, that's basically like collecting fluid. So you can kind of like wash out the area and collect that fluid. You can confirm it by culture, but again, remember with these systemic or endemic fungi, it's a little bit more dangerous to culture them. So if you don't have to, you don't want to. Unfortunately, serological tests are not sensitive or specific enough, so we're not really going to be doing a lot of antibody or antigen testing, but of course we can do nucleic acid tests. For severe and disseminated disease, amphotericin B is going to be the treatment of choice. Why we specify the difference, so severe and disseminated disease is of course far more dangerous for the patient. But remember, when we talked about some of these antifungal therapies, they also can have toxicity to the host. And so amphotericin B, which can cause holes to form in the fungal cell membrane because it binds to that ergosterol, it can also bind to host cholesterol and cause holes to form in our cells. So you want to reserve amphotericin B for really severe disease. For patients that have mild or moderate infections, patients who are not immune compromised or maybe only slightly immune compromised, instead we would prescribe azoles because those have fewer off-target effects and they have less toxicity when compared to something like amphotericin B. In healthy patients, treatment is anywhere from 70 to 95% effective. And again, we're talking about patients who comply with therapy, who haven't developed antifungal resistance. And as you might imagine, the treatment efficacy is lower in patients who are immune compromised. So this is a case study of blastomycosis, central nervous system blastomycosis. The patient was a 56-year-old homeless man from Detroit who presented with a 2-week history of paralysis on the left side. That's what that means. Aphasia, basically kind of difficulty speaking, and generalized headache. These are all indicative of something wrong with the brain, basically. The paralysis, the loss of speech ability, and a headache. No history of rash or respiratory symptoms or fever. Medical history was significant for a left craniotomy, which is a removal of a portion of the skull. So the patient had an intracranial hemorrhage. So basically by removing a portion of the skull, in patients that have hemorrhage and things like that, it can prevent pressure on the brain. And that, pressure on the brain caused by maybe swelling of the brain. And then when the brain swells, the skull doesn't really move. And so that can cause brain damage or death. So by removing a piece of the skull, even temporarily, and allowing the brain to heal allows for the patient to survive. So he was unhoused. He lived in an abandoned building and was not taking any medication. So he had the expressive aphasia. He couldn't talk. He couldn't think of the right words to say. New onset paralysis on the left side. And this thing called bilateral carotid bruti. It's like French, I guess. I don't know. It's not Brutus. I think it looks like Brutus, but it's bruti. It's basically, as a physician is using a stethoscope, they can hear the blood flow. And that's not necessarily a bad thing, but it can be indicative of a bad thing, that you basically, maybe the blood pressure is too high. There may be some narrowing of blood vessels somewhere that's causing really loud blood sounds. The results of the rest of the exam were unremarkable. No HIV, nothing on the chest x-ray. CT scan showed a bunch of lesions with some swelling. He had some generalized atrophy in the left cerebral hemisphere, so the brain was atrophying, it was shrinking. Serum and urine tests were negative for cryptococcus and histoplasma, so we haven't talked about these yet, but they are other fungal infections. Tuberculin skin tests were non-reactive, so it's not TB. Imaging of the sinuses, chest, and abdomen were unremarkable. Brain biopsy was performed. Histopathologic examination revealed granulomatous inflammation and budding yeasts consistent with blastomyces dermatitis. Subsequent culture confirmed the diagnosis of CNS blastomycosis. The patient was treated with dexamethasone and amphotericin B, but developed hypertension and bradycardia with subsequent cardiopulmonary arrest and death. This is an unusual presentation of central nervous system blastomycosis without any other evidence of disseminated disease. The clinical presentation of hypertension, bradycardia, and cardiopulmonary arrest suggests that the patient died of increased intracranial pressure, either as a complication of the infection or the diagnostic brain biopsy. So this is, again, they're saying it's a really weird case. Normally, if you're going to have blastomycosis in the brain, it's probably disseminated from the lungs. And in this patient, maybe it did, but for some reason they were able to clear it from the lungs, but not the brain. It's really hard to say. Perhaps it got inhaled, and instead of going into the lungs, went through the sinuses into the brain. That can happen. Really hard to say. But you can see that this can be a very dangerous infection.